I just wanted to welcome everyone that's in the room today. Today we'll be hearing a presentation on addressing stigma through clinical judgment and strategies for working with families. And today we have a few presenters. So we have Una Saint Amant. She is an associate professor in the School of Nursing at Ryerson University. Her program of research relates to the various intersections of unpaid care work, including family caregiver. We have Angie Hamilton, and Angie Hamilton is a retired lawyer and executive director of the Families for Addiction Recovery. She is a member of the Toronto Drug Strategy Panel, the CSAM Policy Committee, and a board member of the Ontario Family Caregivers Advisory Network. And she has lived experience as a parent of a child with substance use disorder. We also have Brinley Barbeau. Dr. Barbeau works as a family physician in private practice, but she also has extensive experience in mental health and addictions. She is currently an addictions medicine physician at the RAM Clinic, as well as being head of the Service of Addiction Medicine at the Sioux Area Hospital. In addition, Dr. Barbeau, and I hope I'm pronouncing that correctly, is the medical director for the CACC Sexual Assault and Care Clinic, as well as providing primary care to patients with bipolar disorder and schizophrenia. She also brings her experience with a family member with addiction. So I forgot to introduce myself. I'm Rachel Alexander, and I'm a peer advisor on the MedFi Advisory Committee, and very happy to be here today. And I'll hand it over to you. Thanks.
Thank you very much, Rachel. And thank you, everyone. Good morning. We really appreciate you attending this session. So as Rachel mentioned, our presentation is entitled Addressing Stigma Through Clinical Judgment, Strategies for Working with Families. In addition to the presenters today, that is Brinley and Angie and myself, we'd just like to acknowledge our co-authors, Monica Hughes, Dr. Barbara Watts, and Louise White. We do not have any financial support to disclose, nor do we have any external support for this presentation today. So the learning objectives that we'd like to accomplish after today's presentation are to reflect on 3 clinical vignettes related to the application of health laws. We'd like to look at 3 specific health laws related to consent and capacity, harm to self and others, and privacy and clinical practice. We'd also like to engage you, the audience, in a discussion related to the application of these health laws. And we have some interactive questions for you to help facilitate that discussion. Furthermore, we'd like to extend knowledge related to effective family-centered therapeutic approaches in clinical practice. And at the end, we'll discuss some strategies for moving forward. So just to give a little bit of a background, family-centered care refers to the planning and delivery approaches grounded in mutual beneficial partnerships among healthcare providers, service users, and families. Essentially, a family-centered approach recognizes families as partners in healthcare related to quality and safety. And we've seen, high standards and models of care practice in other areas outside of substance use disorder, such as dementia caregiving and other areas of practice where family caregivers are very much considered partners in care. Family caregiver involvement related to substance use disorder is an important and effective strategy for initiating treatment, reducing rates of hospitalization and poisoning. So supportive relationships, especially with parents, have been identified as a significant factor in preventing and managing substance use disorder. Families can play a pivotal role in initiating the treatment for persons with substance use, and families are more likely to seek resources before their loved one. Persons with substance use disorder are less likely to require hospitalization when family caregivers are involved, and that's relatively recent data. Vicarious stigma refers to stigma by association. It's the shame and guilt families feel for their loved ones' behaviors related to their mental illness. And public stigma refers to the stigma families experience as a source of blame for their loved one's illness. And so it's important that we examine these various layers of stigma that are associated with substance use disorder in families. Angie, I'll pass it on to you.
Thanks, Una. I'm going to give a very brief overview of the laws that we're going to need to look at in answering the questions, the polling questions in the vignettes. And the first set of laws are under the Healthcare Consent Act, and they deal with consent and capacity. So patients obviously have to provide informed consent before they can be treated, and they have to have capacity, both if they're consenting and if they're refusing consent. So it's a two-part test. And the first part is they have to be able to understand the information that's relevant to making the decision about treatment. So that's essentially a cognitive test, and generally that test is met. The second one is they have to be able to appreciate the reasonably foreseeable consequences of the decision or lack of a decision. And when somebody is held not to have capacity, it's usually because they've failed this test, which relates to judgment as opposed to cognition. So a few things to know. Capacity is determined by the health practitioner who's proposing treatment. The health practitioner is supposed to assume that the person has capacity unless they have reasons to believe they don't. There is no minimum age. It's not like, well, if you're under a certain age, you don't have capacity. If you're over a certain age, you do. But age would certainly be a factor. Consent must be with respect to each particular treatment. And so somebody could have capacity to make one treatment decision and not another, and their capacity varies over time. The patient can appeal a decision to the Consent and Capacity Review Board. And if they're held to be incapable, then their substitute decision maker makes the decisions. And there's a pecking order of who the substitute decision maker is in our legislation. And many times, and I think you probably all know, there are tensions between what the health practitioner assesses versus how families feel given their connection to the patient and their greater experience with what's going on in that person's life on a day-to-day basis. The next set of rules we're going to look at is the Mental Health Act, which has to do with whether someone can be assessed and held involuntarily for purposes of treatment. Again, that's a two-part test. And the first is if someone is suffering from a mental disorder. If they're not suffering from a mental disorder, these rules do not apply. Question: is substance use disorder a mental disorder? We'll get to that later. The second prong of the test is if their mental disorder is likely to result in serious bodily harm to themselves or to others, or if there's serious physical impairment of the person unless they remain in the custody of a psychiatric facility. So a few things to know here. Likely means probable. Serious bodily harm has been held by the courts to include psychological and emotional harm. And since 2000, the requirement that the harm be imminent has been removed. So as long as the harm is going to be incurred in a reasonable period of time after discharge would be the test. The last set of rules are the Personal Health Information Protection Act, which provides rules regarding the collection, use, and disclosure of personal health information about patients to protect privacy and facilitate the effective provision of health care. And if the patient is not capable of making treatment decisions, then it's their substitute decision maker who's entitled to receive the relevant information and to make decisions. I would say that there's quite a bit of confusion regarding the ability to collect information without consent. So in other words, they're not disclosing anything, but they're receiving information from family members. I can tell you often family members are really desperate to share information. So generally, without the consent of the patient, the healthcare provider is not supposed to collect the information, but there are exceptions. And for example, one exception is if the information is necessary for the provision of healthcare and direct collection, so from the patient, is not reasonably possible because you feel that the information is not accurate or complete or could not be acquired in a timely manner. Thanks.
Okay, I'm going to read our first clinical vignette. So this is about Shahir. So Shahir's medical history, he has substance use disorder. He's been homeless in the past. He's had a previous overdose in February 2021 on fentanyl. Naloxone was administered at the time. History of depression and anxiety, and currently has no fixed address. So the EMS report comes in. Shahir, a 17-year-old male, was found unresponsive in a stairwell. A stranger called 911. Upon arrival, he had slow agonal respirations, bradycardia, an irregular heart rate. He was hypotensive and hypoxic and had mild hypothermia. His skin was clammy and cool to the touch with generalized pallor. He had a slow capillary refill. His pupils were myotic. The paramedics administered naloxone ×2 with effect. He was started on oxygen via nasal prong, and IV access was obtained, and he was brought to the hospital. So later in the ER, he was stabilized, but he arrived unaccompanied. Despite being oriented ×3 after his stabilization, he had periods of restlessness and agitation. He had a visible open fracture of his left radial and ulnar bones. And at this point, he refuses contact with his family. Later that day, he goes on to have surgery for his open fracture. The next day, he's febrile, tachycardic, dyspneic. Blood cultures were drawn from the day before, and they're growing gram-positive cocci. He was then started on IV antibiotics for presumed endocarditis, and his echocardiogram was pending. So later that same day in the post-op unit, he is refusing care and preparing to leave AMA. So we have some polling questions. So I'm not going to, you have to scroll down. There are 4 questions in total, and you can just answer yes or no to them. Go with your gut feeling, and we're going to review these questions at the end of our presentation. I'll give you a minute to read through the questions and to answer those.
Okay, so our next clinical vignette relates to FAYE. And so I'll just read you about the description of FAYE, and you can see on the screen as well her information. So she has a history of depression, anxiety disorder, and anorexia nervosa. She was admitted, or the EMS report upon arrival at the emergency department. FAYE is a 16-year-old female and was found unresponsive in a stairwell. Her parents called 911. Upon arrival, the patient had irregular respirations, respiration rate of 35, shortness of breath, pulmonary crepitations at the bases of lungs, bradycardia with irregular rhythm, heart rate 39, hypotensive with blood pressure of 70/30, and mild hypothermia, temp was 35. She appeared cachectic. Patient was started on O2 via nasal prongs. IV access was obtained, and she was brought to the hospital. At the ER, the patient was stabilized and arrived unaccompanied. Despite being oriented ×3 after stabilization, the patient had periods of restlessness and agitation. The patient has visible open fracture of the left radial and ulnar bones and refused contact with family. A little later on, the chest x-ray showed pulmonary venous redistribution. The ECG was ordered, and the patient has suspected CHF. Later on, the patient has surgery for the open fracture. And the next day, in the post-operative unit, the patient refuses care and is preparing to leave AMA. So very similar to our previous polling questions, we have some more polling questions for you related to FAYE. So if you could just take a minute and respond to this poll.
Thank you. So the third vignette is Edward. So his medical history includes dementia with a mini mental status exam score of 20, COPD, type 2 diabetes, and a previous hip replacement in 2014. So for Edward, he is an 84-year-old male who was found unresponsive in a stairwell. A staff member at his retirement home called 911. So upon arrival to hospital, he was tachypnic, tachycardic with an irregular rhythm, as well as being hypotensive and hypoxic on room air. And he was also febrile. He was started on O2. IV access was obtained via nasal prong, and he was brought to hospital. So later in the ER, he was stabilized, but he arrived unaccompanied. He was oriented ×3 after stabilization. He had periods of restlessness and agitation. He had a visible open fracture of his left radial and ulnar bones. He refuses contact with his family. Later that day, he goes on to have surgery for his open fracture. The next day, he becomes febrile, tachycardic, tachypnic, and his oxygen is 95% on 5 liters via nasal prongs. His chest x-ray shows a left lower lobe pneumonia, and he started on IV antibiotics. So later the same day in the post-op unit, he refuses care and is preparing to leave AMA. So this is our last clinical vignette. So this vignette only has 3 questions, but similar to the others, yes, no answers, and we'll review and discuss all at the end.
Thank you. I'll start again. I just want to take a few minutes to talk about our laws before we discuss the vignettes. And I want to start by shedding some light on FAYE's vignette, and she's the young woman with anorexia nervosa. So there is a recent consent and capacity board decision dealing with a 20-year-old woman who was found to lack capacity to make treatment decisions regarding her eating disorder. Essentially, she failed the second test because she did not believe she had anorexia nervosa, and therefore she could not appreciate the consequences of receiving or not receiving treatment. And this is consistent with actually a Supreme Court of Canada decision in the Starson case, which basically said if someone doesn't understand that they're affected by a condition, they're not going to understand that they need treatment. They're not going to understand the importance of receiving or not receiving treatment. So in this case, treatment was provided with the consent of her substitute decision makers, which were her parents. This illustrates that the determination of capacity, it really is, and it can be and often is, a life or death decision. And to err, on either side is probably to deprive somebody of their rights. If the person really has capacity and the physician decides they don't, and the substitute decision maker makes a decision, then we've kind of deprived the patient of their right to make their own decisions, and vice versa. So these are really important decisions, and that's all I really want to say about that at this point. So the question of, does the Mental Health Act apply to substance use disorder? There's an excellent paper in 2020 by Vicky Sturgiopoulos at CAMH and a whole bunch of other co-authors called Rethinking Involuntary Admissions for Individuals Presenting to EDs with Life-Threatening Substance Use Disorders. And essentially, it looked at the criteria for detaining someone involuntarily under the Mental Health Act and concluded that, yes, the first criteria, is it a mental disorder? It is in the DSM. And not only that, there's a plethora of cases that say that substance use disorder is a mental disorder. So that test is met. And the second one, in particular cases, can somebody be at risk of serious bodily harm or serious physical impairment? Obviously, for example, yesterday in I think a couple of the presentations, it was said that somebody who presents at the ER with an overdose their mortality rate, I think, is 5.3% in the next year. So clearly, these provisions can absolutely apply in the case of substance use disorder. The problem becomes, and I think this is why it's not being used, is one, that there aren't a lot of beds in psych wards, and two, the argument could be made, and I think I would agree with it, that a locked psych ward is not the right place for people with primarily substance use disorder. And that's another issue which we can address later. I do want to spend a minute just to look at this issue in a different light, from the point of view of the Ontario Human Rights Code, which clearly says substance use disorder is a disability. And this case of Sunnyside Home is where a nurse who was working in a long-term care facility was caught stealing pain medications from patients. She had opioid use disorder. She was fired. She went to rehab. She recovered. She wanted her job back. Her employer said no, and the union took it to the tribunal. And the tribunal, after listening to witness testimony, not witness, but expert testimony, found that opioid use disorder is a mental disorder characterized by compulsive behavior and either a complete inability or a diminished capacity to resist the urge to engage in behavior supporting their addiction. So, in other words, it's really a lack of autonomy with respect to your use and what you have to do to get it. So, in this case, the employer had to accommodate the employee in the workplace unless it was going to cause undue hardship. Does anosognosia, or lack of insight, apply to people with substance use disorder? And I actually want to read a quote. Of the 20 million people in the United States who suffer from a substance use disorder, 19 million of them, 95%, say they don't need help, according to the 2013 National Survey on Drug Use and Health. That is remarkably high regardless of symptoms or their severity. Even 90% of the over 8 million people who experience substance-related withdrawal symptoms, trembling hands, seizures, hallucinations, don't believe they need addiction care. And that is from an article in the Boston Globe in 2015. And I would say that which interestingly enough, the article was mostly about CRAFT, community reinforcement and family training, which is approach we use in training our family peer supporters. But this does reflect the experience of our families, that often people do lack insight into their condition. So this is from BC. Ali Thomas, who was 12 years old, died of her fourth overdose. And I can't guarantee that she was in the emergency department the 3 prior times. It does read that way, at least some of the times from the newspaper article. The status quo across Canada is we are allowing everybody, including youth, who are addicted to illegal substances to play Russian roulette with their lives. So the drug market is toxic. Their next use can be fatal. Could this situation have happened in Ontario? I absolutely believe the answer is yes. I know with children slightly older than that, it has. In 2018 and 2019, 1 in 6 deaths of Ontarians 15 to 24 years old was opioid related. That was 128 people in one year and 129 in the other. So I would point out that we're intervening for young adults who have life-threatening anorexia nervosa. And I think more often than not, it's fair to say we're not intervening for minors with substance use disorder. So I'd really like to know I think it would be really interesting to see if the protocols are different in any way in children's hospitals where someone presents with an overdose than in other hospitals. I'd love to know what the position of the Canadian Pediatric Society is with respect to decriminalization, regulation of drugs, safer supply, involuntary treatment. These are the discussions we are not having, and the silence is deafening, and children are dying. The last point I want to make is, again, just bringing home the comparison of what's going on under our human rights legislation versus what's going on under our health laws. The Sunnyside Homes case illustrates that we are protecting the livelihoods of very functional employees because they have substance use disorders, which are a disability and detrimentally affect a person's autonomy. At the same time, our health laws, either as drafted or applied, are not protecting the lives of youth with substance use disorders because of perceived patient autonomy. Una? Oh, sorry. I do have 3 other slides. I don't really want to discuss them right now regarding what a rights-based approach would look like. You can look at them later, or you can ask me questions during the question period. I just want to make sure we've got lots of time for discussion and chatting at the end. Una?
Thank you. So the goal of our analysis today is not to suggest that we should all indiscriminately assume that family members play a positive role in supporting persons with SUD. However, at the same time, we are also advocating not to hold prejudice against families either. We'd like also to highlight how in other illness contexts, family caregivers and their involvement in care is often treated differently. For example, in dementia care, there are generally no presumptions of family dysfunction or abuse. Caregivers are often perceived as care partners and acknowledged as such. And at times, they're even assessed with tools like the RIE. When it comes to substance use disorder, families are often presumed to be the problem, the etiology, or the source of dysfunction. And they are often seen as a source of abuse and excluded from care. It's important to question that exclusion and what informs perceptions of family, especially when the bulk of care is done by families, and many persons with substance use disorder live at home and in a family setting. Furthermore, there is a need to improve understanding and application of health laws related to mental illness and in particular substance use disorder. A 2020 commentary from the Canadian Association of Emergency Physicians speculated that there's an underutilization of legal provisions for persons with substance use disorder, and the authors questioned whether a lack of awareness and publicly available legal precedents of legislation inform this issue. As family members, and all of us on this panel are family members of someone with a substance use disorder, we recognize that issues of capacity are very difficult, and often it's even more difficult for families than it is for providers. Involuntary service is not ideal nor desired as the first choice approach for many family members. However, when the situation is life-threatening, it's necessary. And it needs to be considered as a tool among other tools for responding to substance use disorder, especially when it comes to youth. We recognize that compounding the issue is that many patients with substance use disorder simply have no place to go, particularly when there's evidence-based, high-quality, universally accessible care provisions for persons with substance use disorder have not yet occurred. We still need a lot of work done in terms of where they can go once they're held. There's a need for both person and family-centered care. And thinking about some practical strategies, a few suggestions that we have related to the case scenarios would be things like to reassess family involvement when their involvement is refused. So if the patient says no the first time, it's possible that they may, if assessed again, they may request family involvement. Not to assume that all family is problematic. And if there are situations where family is deemed, problematic, and they do indeed play a caregiving role, it's important to link them to family resources. For example, there are caregiver training programs that are available to develop caregiving skills. So it's not, it's not necessarily a dichotomy in terms of no involvement and never have any involvement. Sometimes there's opportunity to enhance that involvement with families. So those are essentially our ways forward. At this time, we would like to open up the discussion to the vignettes, looking at some of the results. It appears that, for the first case scenario related to substance use disorder, some people chose to involve family, whereas for the second two polls related to FAYE with an anorexia nervosa and Edward with dementia, most people chose to involve family. So those are some interesting findings from our polling. And we'd like to provide the audience with an opportunity to ask some questions now. So I'm just, if it's okay, Rachel, I just see a question in the chat, so I'll just pose it. The question is, what do you think needs to change in order to support involuntary admission for substance use disorder? Angie, perhaps you'd like to take that one.
Yeah, I like everything, but it all starts with conversations. We've been trying to get our government to look at this, trying to get the medical profession to look at this for years now, and nothing has changed. There's tremendous resistance to it. There were actually recommendations made to the government in 2010 as a result of an all-party committee report on addiction and mental health, which clearly said we needed to make amendments to our involuntary treatment laws in Ontario, and it went so far as to suggest what the amendments should be. And they said they would do it in 2011, and they haven't touched it since. And the reason is because I would say a lot of this is very, very shallow discussions on what a rights-based approach to this is. And families, I think sometimes people think involuntary treatment is the big bad government trying to get, provide punishment to people who are mentally ill. I think it's important to understand that there are a lot of families that are requesting these provisions because we are the experts. A lot of us are family caregivers providing care to our loved ones. We know what's going on a day-to-day basis, and we're not being supported, and we see them, really, no matter how young and their life being at risk, they can be homeless and it's not dealt with. So the government they don't like division, and this is a divisive issue. I don't think if we actually had a lot of discussions, it would be divisive. Um, and I guess that's going back to my slides on what a rights-based approach is. But I honestly thought it would be a rhetorical question if someone doesn't want to die and their right to refuse treatment is in conflict with their right to life and security of the person, that we would prioritize their right to life. However, that apparently is not only not a rhetorical question, but we have some pretty influential organizations like the UN Committee on the Rights of the Convention of the Rights of the Disabled, and more recently the World Health Organization coming out and saying involuntary treatment, coerced treatment is always wrong, always a violation of rights, never in anybody's best interest. So that's problematic. So advocacy work is required, and conversations are required.
I think as well, from the medical perspective, I think to improving resources, because If we determine that a person requires treatment, we have to be able to provide that treatment. And right now, there's a lack of services. We wouldn't, if for everybody who came in at present, we wouldn't have the beds, the places to put them. So that's another aspect, is ensuring that we have adequate services if we determine that patients require them.
Thank you, Brinley and Angie. I'm just seeing another question in the chat, do you think a rights-based approach conflicts with an evidence-based approach and the evidence for or against the effectiveness of involuntary admission for substance use disorder?
So, no, I don't. There is, I'm going to just go with a culture in Canada that everybody knows involuntary treatment doesn't work. And no, that's just not correct. What is correct is there is an overwhelming lack of evidence either way. And there's a problem even with just looking at it that way, because it's designed to solve a problem, the problem of what if somebody lacks capacity to make treatment decisions, or what if someone is at serious risk of harm to themselves or others. If you say, well, the answer to that is involuntary treatment doesn't work, well, what is the better solution then? You're just going to let them, harm themselves to death when they don't want to die, or let them, harm someone else, or let them make treatment decisions when they don't have capacity to make treatment decisions. It's actually the wrong question, but I understand its importance. The truth of the matter is most people in Canada and everywhere aren't getting evidence-based treatment for substance use disorder, voluntarily or involuntarily. So, I want to endorse what Brinley said, which is an excellent point and gets raised all the time. How can we, look at involuntary treatment when the people who want to go can't get help? And that is an excellent point. I would also point out that's mental health triage. We're watching physicians with great angst right now in Alberta, worried that they're going to have to triage COVID patients because they can't treat them all. When we say things for in the realm of mental health, like they have to want help, uh, uh, you know, um, it, it leaves us with a situation where we're really saying the most severely ill who don't understand they're ill, we're depriving them of any chance of recovery. And that, I question the ethics of that. That is mental health triage. I think we have to acknowledge that. Um, right now, there are a lot of people questioning the ethics of people who, believe that there is a place for involuntary treatment. I want to make it clear, this is not a solution to the opioid epidemic. This has a lot to do with alcohol use disorder, frankly, where, safer supply is not going to send supervised consumption sites, not going to save people right now with alcohol use disorder. That's not the problem. The problem is often they lack insight and they aren't seeking treatment. And I think it's important to address that right alongside of addressing the lack of capacity in the system to treat people. I think that is the easiest thing to do, is to make sure and work towards treatment on demand, because bad things happen when people wait for treatment. They commit suicide, they change their mind about getting treatment, they die, they're homeless, they go to jail. Bad things happen when people wait for treatment. I would just add, those same bad things happen when they aren't seeking treatment.
But I was just wondering if you could speak to some of the resources. You said that, one of the things that we could do is offer resources to families. You also mentioned CRAFT, which is like a training. I'm semi-familiar with it. But if you wanted to, I don't know, just expand on those resources and what that would look like in conversation with a family.
That's a great question. Thank you. And yes, I'm really excited about the CRAFT approach, which we train all of our peers in it. So it is a non-confrontational approach and a compassionate and empathetic approach to your relationship with your loved one who has a substance use disorder. And it absolutely is an evidence-based approach. We also use motivational interviewing and acceptance and commitment therapy. So I find it really interesting. The families are on their parallel journey with their loved one, who has substance use disorder. So the person with substance use disorders, realizing they've got a lack of control over their use, and the family's realizing we got a lack of control over our loved one. And like the idea that we ever had it is ridiculous. But what happens in families sometimes is there's fear because you can see so clearly they're harming themselves, and they're ambivalent. They're getting, and so it's really important for families to understand, hey, people aren't crazy because they use substances. They're using for a reason. They're getting something out of it. Come at it from that perspective. It makes sense to them. So it's accepting that they are getting something out of it. And how scary is it if that's become their main coping technique to deal with, inevitably pain, physical, mental, trauma, whatever it is. They're using it to cope. If that's the rug they're standing on and you're going, well, let's just whip that out from underneath you, and leave you with nothing. It takes a while to build up coping skills. That's very frightening. So it's designed to, I would say, really keep the bond with your loved one, as much as possible, to not focus on the substance use, which really is not in your control, but focus on your relationship with your loved one. So boundaries are very important, but they're not there to punish your loved one. They're there to protect your own mental health and the mental health of maybe other people in the family, because it's so hard to watch loved ones struggle and self-harm. And sometimes families do have to, I'm not going to say detach with love, but they have to set a boundary to protect themselves. And what's good about that is it allows the empathy and compassion to flow. If you feel like a doormat, if you feel like you're working on your loved one's recovery more than they are, then you're going to have resentment. You may say things you regret. You may get angry. Like, to me, a good indication if your boundaries are in the right place is if you're angry or not. And while I can validate it's kind of normal to get angry because it's fear-based, it is, I can also say, completely unhelpful. And so we can really help them. And so I think, if just like peer support is important for the person with substance use disorder, it is equally important for the family members. And it's wonderful when you're talking to somebody who's been through it, because they don't say they don't give you unhelpful advice. They listen without judgment. And that's a lot. Like, we have a lot of family members who say, I can't talk to anybody. And the stigma is just as big for the families as for the person.
Thanks, Angie. And I agree with everything you've said. And I think there's also, an opportunity for more resources. If you look at other models of care with caregivers, especially, the achievements of dementia caregivers, it's just been remarkable, what kind of resources have become available. The work of caregivers has been more pronounced and acknowledged within the healthcare system. They're referred to as partners. There's really been a lot of, I think, social movement towards positive imaging of caregivers. And it would be, I think that there's opportunity to see some of those shifts to a substance use, and to sort of shed this perception that all family are bad or that all family are toxic, because we really need to move away from that, especially when family can be helpful. And especially when family is doing all the work. It's a lot of times it's, they're doing the day-to-day and they're living with their loved one and they're doing the best they can. And then when there's these crises, they are excluded from the care. And so thinking about how we can enhance some of those relationships, without taking, without shifting to all family as positive necessarily, but, really acknowledging that there are those positive supports for loved ones. or comments about the vignettes, if there's resonance there, if people feel that, there was any change in perception, or if the vignettes sort of, if you noticed the vignettes were intentional in terms of the patient profile all had sort of a similar situation happening. The only difference really was in terms of their medical history. So if that had any resonance. Oh, great. We've got another comment or question here. In the US, there is a culture of involuntary admission for substance use disorder. What good or bad might be learned from this? Excellent question. Thank you.
So that's interesting. I don't think there's a culture of involuntary admission. And if you talk to the families down there, they're pretty frustrated too. But it is allowed in 37 states for adults, not just minors. So it is a different culture. But I don't think it's that common. And what good or bad might be learned from this? I- There's a place for this. 100% of people don't have capacity to make treatment decisions 100% of the time. And sometimes people are at serious risk of harm to themselves or others, and they're not seeking treatment. That's what involuntary treatment is designed to solve. And again, if you say it doesn't work, what is your better solution? You need to come to the table with something that I'm all ears, love to hear it. You can't, I don't think it's a compassionate approach to just let people, for example, let's switch to alcohol, because boy, part of the problem is the whole legal and illegal drug thing, which I would say right now I support drug policy reform absolutely. But if we just focus right now on alcohol, again, safer supply, consumption sites, that's not going to save people who are drinking themselves to death. And so what is a compassionate approach for them if they lack insight? And I have seen on Twitter or the Medify listserv situations where physicians are sick because their patient is pre-contemplative in that list of, are you ready for change? They're literally pre-contemplative, and they're dying from alcohol use disorder. Well, I really do feel like alarm bells need to be going off there about whether that person has capacity to make treatment decisions. And if I'm their substitute decision maker, I'm not happy that I can't make those decisions and that there's nowhere for them to go to, to help them. And I guess the one thing I would add is, you know, um, people, they tend to think this means lock psych wards. This does not mean lock psych wards. My son was in a place in the States voluntarily. We were paying thousands of dollars a month for him to be there. Right beside him, somebody court mandated there, and no locks on the doors. There's no point in leaving because they're going to bring you back. And there's lots of models of that in the States for youth. You want to keep them in as normal an environment for youth as possible. That could be like a therapeutic boarding school, because it's when people can't be safe for a period of time in their community. They need to be removed from the community while they build up their coping skills, just like adults sometimes need residential treatment. So do youth. And it should be as normal as possible. It's not a locked psych ward. In Canada, we have very few of these places. We do have Pine River Institute in Ontario. It's wonderful. 200 kids on the wait list, 14-month wait.
Angie, there's another comment here, or question. Any comments on the role of Al-Anon for families, or even the user after a period of sobriety?
I like Al-Anon as an option for everybody. I went for years, and it helped until it didn't. For families, I love the 3 C's. You didn't cause it, you can't control it, you can't cure it. That's gold, and families need to hear that. So there absolutely is a role for it. Again, it's a form of peer support. I prefer the craft approach, I would say. And is there for the person with substance use disorder? Absolutely. Again, it's peer support. To me, it's not treatment. It's peer support, and it is evidence-based. There's uh, what's it, the research Recovery Research Institute, um, which is I think a Harvard group, and they did research, and it is evidence-based. Again, I would say not treatment in and of itself, but can be excellent peer support. Unfortunately, I think there are still some Al-Anon groups that don't view people, um, who are on medication-assisted treatment as in recovery, which personally I find ridiculous. And I think that it's less and less and less every day. And smart recovery is great for families and for people with substance use disorder. There's none of this like higher power, which some people have a hard time with, even though, they say it can be your group or anything. There's a place for it. It depends. It's all up to the person, right? And same with the family. It's what works for you.
I agree. And I think people have to do what works for them. And, I think there is a place for anonymity if that's important to that person. But I also worry that, it reinforces that this sort of support has to happen in hidden spaces, and that we're not supposed to talk about it. We're not supposed to, advocate for change or have these experiences sort of in shame. And so as much as I feel Al-Anon is an important strategy for some families, and it should be, I just, I think I think caregivers need to get loud and start, advocating for change. And I think they're part of the solution and not the problem. So I think that's a wonderful comment and question. Thank you for that.
Well said, and that is part of why Families for Addiction Recovery exists. It was because of the lack of advocacy work, all around. Like, we need drug policy reform, we need health law reform, we need resources. I mean, and in some respects, our system right now, if somebody said design a system to kill people, I'm sorry, it would be the one we have today, especially people who need residential treatment. Let's let them wait for detox, and then they get into that, and then they can white knuckle it 6 weeks while they wait for the residential treatment. If they could wait 6 weeks for residential treatment, they wouldn't need residential treatment. So, that needs to be incorporated. It needs to be a seamless flow from one to the other. And then we absolutely urgently need OAT in the residential, community and rehabs. You can't say, well, yeah, you need to be, a safe space for a while, but we're not going to give you the gold standard of care for you. There's so much that needs to change.
Thank you so much, Angie. I couldn't agree more. As someone who's been on sort of both sides of that, of addiction. So I really, really appreciated everyone's what they shared today. And unfortunately, we do have to wrap up. That's the end of the session. So I just wanted to thank all of you and also the participants for their questions and for coming and attending and engaging in this presentation. And yeah, if you have any, last few words or anything, I just wanted to thank you. And yeah, thanks.
Thanks everybody for coming.
Thank you.
And let's continue the conversation, please. To be continued. Thanks.